faculty, staff of Mount St. Mary's College, my classmates from Mount St. Mary's Academy, graduation 1963, my friends from Bishop Dunn, and the wonderful nursing students. It is indeed a great pleasure, I'll sound like Tony the Tiger, pleasure for me to be here. I am so delighted to see the change in this beautiful college. And I want to take this opportunity to thank the faculty and staff for all they have done to create a wonderful learning environment. My presentation today is entitled Getting to Zero in Liberia. The title comes from a campaign that was started by UNAIDS in 2010. And they have challenged all the nations of the world to do everything that they can to get to zero. Zero new HIV infections, zero new HIV-related death, and zero stigma and discrimination. It's quite a challenge, worldwide challenge, but many nations have embraced this concept and have intensified and upscaled the HIV programming and implementation. I would also like to note that getting to zero is the global theme for World AIDS Day and has been for the past 3 years. There's a global theme, and then each country comes up with a country theme that will fit into the concept of getting to zero. The presentation is very brief. I would like to leave enough room for questions, and I assure you I don't have every answer in the world, but I brought my handy computer that I think's got all the answers, so feel free to ask anything. But I would like to paint a picture of Liberia for you so you can appreciate the context in which I will be talking. Secondly, I would like to talk about the epidemiology of HIV, looking at the global epidemic, the epidemic in Liberia, and what are some of the drivers of the epidemic, and I will look specifically at Liberia. What is the national HIV response, and what have we done towards moving Liberia towards getting to zero? And lastly, the challenges and the way forward. Liberia, sweet land of liberty, that's what it's called. It's located on the west coast of Africa, bordering on the north by the North Atlantic, Sierra Leone, the Ivory Coast, and Guinea. Liberia is a beautiful country, a beautiful landscape. It's located just a little bit below the equator. It's got tropical rainforests. It's absolutely gorgeous. Sometime when I come back, I'll bring you pictures and talk just about the beauty of Liberia. I have to share with you that Liberia is emerging or has emerged from many, many civil conflicts from 1990 to 2003. And during those years, many, many people, I believe the estimate is about 250,000 individuals lost their lives. All infrastructure, whether it's medical, social, were either damaged, destroyed, or polluted, or looted, I should say, I'm sorry. But we are happy that the wars came to an end in 2003, and in 2005, we elected the first female president, President Ellen Johnson Sirleaf, on the continent of Africa. When you look at the population of Liberia, we are a very young population. Approximately 54% of the population is below the age of 20. This is a great opportunity to chart a future that everyone can live in peace and enjoy the prosperity. When you talk about Liberia, many people say, oh, that's a poor country. But I'm here to tell you that the country is a rich country. It's rich in natural resources, iron ore, gold, diamond, timber, beautiful white sandy beaches, and I can go on and on. Unfortunately, the people are poor. So it is a challenge for the government to turn it around so that everyone can benefit from the natural resources. When you look at the economy, I believe approximately 70% of the population is unemployed. Many of our girl children do not go to school. We have compulsory primary education, which is free, or which is supposed to be free. And I say supposed to be free because there are many factors that can affect a child's ability to go to school. If the classroom sessions are free, who buys the uniforms? Who pays for the books? So these are challenges that we are facing on a daily basis, and I'd like to say I believe we are up to the task. Let's look for a minute at the global HIV epidemic. This chart comes from UNAIDS, that is the United Nations Joint Program on HIV, the report from 2012, so it's fairly recent. I put sub-Saharan Africa number one, or they did. Adults and children living with HIV is 25 million. There's always a range to these figures when UNAIDS make their report. It is for the adults in sub-Saharan Africa, it is between 23 and 28 million. This represents 69% of all people living with HIV. It's quite significant. The majority of the children who are infected with the virus live in sub-Saharan Africa. The greatest number of deaths live in sub-Saharan Africa. In 2012, 1.6 million adults and children were infected. The overall HIV prevalence rate for sub-Saharan Africa is 4.7. You may think that this is high, but I'd just like to say that we have made great progress. A few years ago, if I had given this talk, I would have said to you that 90% of individuals infected with the virus live in sub-Saharan Africa. We have managed through the years to bring that down to 69%. I'll let you out. I don't want to take the time to read each region, but I did include it in case someone in the audience have particular interest in any of the regions. I would like to skip to North America, was home for you. Liberia, I might add, is located in sub-Saharan Africa. So our general overall HIV statistics are reflected in the numbers I just read. In North America, approximately 1.3 million people living with HIV, 48,000 adults and children newly infected with a prevalence rate of 0.5% and 20,000 deaths in 2012. It's important to note that in North America and in Western Europe, HIV has become a chronic condition. you are where the rest of us are striving to be, and I'll make this point throughout my presentation. In Liberia, we have not reached the point where we can look at HIV as a chronic condition. Are you hearing me okay back there? Okay, great. But we're working towards that goal. Now let's look at Liberia, the sweet land of liberty. The first case of HIV was reported way back in 1986 in a cross-border worker. In 1987, the government of Liberia established the National AIDS and STI Control Program, which was an arm of the Ministry of Health. The initial attempts to make a dent in tackling this virus was hampered by the civil wars and civil unrest in the country. In 2010, the National AIDS Commission was established, and I'll say a little bit more about that later. But let's look at the epidemiology of HIV in Liberia. We are at 1.5% prevalence rate. And you'll note that I'm quoting figures from 2007 from the Liberia Demographic and Health Survey. That's the latest information we've got. In 2013, another health and demographic survey was done. It has been completed, and we are looking forward to the results, preliminary results, at the end of October, beginning November. And we are all hoping that we have brought the prevalence rate down. When you look at the prevalence rate within pregnant women, it's at 2.6%. And that information comes from the 2011 Antenatal Clinic and the National AIDS Control Program, commonly known as NACP, data. You might think, boy, that's high. But in 2006, when the first ANC survey was done, the prevalence rate was, the average was 5.7%, and it got to be as high as 9 and 10% in some of the areas. This was an attention-getting result, or these were. There are 1,684 pregnant women living with HIV and approximately 33 plus people within the country that are infected with the virus. I want you to note that 60% of this number represents females. They always say that the face of HIV in Africa is young and is female. And if you read the literature, you will see that this is quite true. So a lot of emphasis, a lot of efforts have to be placed in educating young women and young girls about HIV. And we're talking that with your instructor today that most of you, the nursing students, are in community health. These statistics I'm sharing with you today are from Liberia, but communities across the world have many common strands, if you will. When I was first invited to do this talk, I gladly accepted for a number of reasons, but my comment was, we now live in a global society, and it's important for each and every one of us to learn about another culture and about those health and risk factors that affect other people on other continents. No one could have told me that when I was a young girl growing up in Liberia, that I would spend my formative years in a Catholic boarding school in a place called Newburgh, New York. I had never even heard of it, but it happened. And I say to young people, you have to learn about other cultures. because you will be mobile and you need to interact with different people. In Liberia, we have both types of HIV present, HIV-1 and HIV-2. HIV-1, of course, is the most prevalent HIV strand. HIV-2 is found almost entirely in Western Africa. The primary difference between HIV-1 and HIV-2, HIV-2 is a little bit more difficult in the transmission mode, and it takes a longer time before people have AIDS-related complications. Now, what does this mean for people with HIV-2 infection? And I'm not going to give you a lesson on HIV. But what it means is, if you are getting infected with this virus, HIV-2, longer before the manifestation, then the virus, as you know, begins to multiply after you are infected. And so it takes a longer time, but the whole while, your immune system is being destroyed by the virus. Other than those differences, the presentation of the disease, the modes of transmission are the same. Approximately 1,300 new infections in Liberia, and 3,265 Liberians died of AIDS-related causes, and that data comes from the Spectrum report. When you look at the difference between men and women, girls and young girls and boys, the prevalence rate among women is 1.8% versus 1.2%. In our part of the world, young women have a greater risk that is 3 times higher than their male counterparts. In Liberia, when this data came out, it told me that 10,000 people needed ARV treatment. Now in 2013, the number has gone up to 17,000 in need of ARV, and ARV is antiretroviral treatment. The increase, I'm sure, is related to the new guidelines that WHO has put out. HIV, interestingly enough, it's the only condition that I can think of that we generally wait until it gets worse before we initiate treatment. Up until earlier this year, and we followed the World Health Organization guidelines, they recommended that we initiated treatment when your CD4 cell was about 250. Remember, I said that the virus begins to destroy your immune system the minute you become infected. We were all very excited that WHO has increased the threshold to start treatment. We can now start treatment at 350 CD4 count. What this means really is that you have more people who are eligible for treatment. The ARVs, the antiretroviral drugs, are not cheap, and therefore countries have to begin to look at how they can upscale, upgrade the whole aspect of treatment care and support. In 2011, we had only 6,000 out of the potential pool of 10,000 people on ARV. For those who are going into community health, there is a ratio difference between urban HIV prevalence rate, as you would expect, and rural. In the cities, the prevalence rate is about 2.5% compared to 0.8% in the villages. TB, that has been under control in a lot of different places, is still a problem in our area, And TB and HIV co-infections is a major problem. We're now trying very hard to work very closely with the TB control arm of the Ministry of Health, so that if you're diagnosed HIV positive, then you would also be tested for TB. And if you have TB, we encourage you to be tested for HIV. There needs to be, and it was identified as a gap in our strategies, that we do not communicate enough with the other programs, so there's a major effort in this area. Lastly, the children are affected. In Liberia, which is a small country, the country overall population is 3.9 million people, and we've got 49,000 plus orphans as a result of HIV. I put this slide there so that you can appreciate the male to female ratio. If you can look between the ages of 15 and let's say 34, the females are infected more often than the male. We'll talk a little bit more about the factors that influence this. What are some of the drivers of the epidemic? And I'm looking specifically at Liberia. Number one is the impact of war and extreme poverty. One of the articles that I read tells me that between 75 and 79% of the people live in poverty below the international standard. It also says that with extreme poverty, the individual vulnerability to HIV is increased. And when you look at the boys and girls, many of them, just to survive, get involved in transactional sex. By definition, very quickly, transactional sex is you've got what I need, a commodity of whatever, and I've got a beautiful body. So let's get together, you get what I need, and I will have sex. It's an arrangement. The collapse of the health system has been a driver. Many people wait until they are very sick before they even try to access services. Even though we've made a lot of progress since the war, the capacity of the health system is still low, even though there are partners that are investing in strengthening the capacity of the healthcare system in Liberia. And lastly, there are high levels of sexually transmitted infections. I could stand up all day and talk to you about the level of sexual gender-based violence. It is a problem. We're trying very hard to deal with it. And one of the challenges is that if there has been an incident of sexual gender-based violence, many people say they want to handle it the family way. They don't want the perpetrators prosecuted. And because of the level of poverty and the somewhat underdeveloped structures, if I bring a complaint, many times I may have to provide fuel for the motorbikes, for the policemen to go and investigate the problem. There are other out-of-the-pocket expenses, so many people say, and the saying is, let it be so. But again, we are working to change that because there is a link, there are linkages between gender-based violence and HIV, definitely so. Social and cultural practices that foster inequality. I can say right off the bat that Liberia, there is an imbalance of power between male and female, with the males being more powerful. They are the ones that have the opportunity to go to school. People favor sending the boy child to school as opposed to their girl child. If a family member is ill with HIV, the person who stays home and missed class will be the female child. So there is definitely a gender inequality. There is also early marriages. One of the articles I read recently says that many girls in the villages are married by the age of 14 and 16. Keep in mind, however, that they're not marrying their peers. They are generally being married off to older, more sexually experienced men. And so they are at risk. Early initiation of sexual debut. The article that I'm reporting here tells me that 17%. See, I'm looking at the computer and I'm moving the slides. Oops. Sorry about that. No. Yeah. 17% of girls and 9% of boys have had their first sexual experience by the time they are age 15. Other studies that have been done tells me that that threshold is age 13. I want to call your attention to the fact that if you know, and you are as educated as I am, know that girls are having their first sexual experience at the age of 13, and you believe in your heart that the only way you can be protected from getting infected with the virus is if you sleep with a virgin. In some parts of Africa and in some parts of Liberia, there is a belief that sleeping with a young person has the power to cure HIV. We know that these are myths. But what that says to me is we need to be very careful with our young girls because older men are targeting girls as young as 9, 10, 11. Nobody wants an older teen because they have had their sexual experience. Food for thought and places where we need to put our emphasis in terms of educating not only the children, but educating the parents in the best way that they can protect their children. Then you have to deal with high level of informal, multiple, and concurrent partners in Liberia. Nobody seems to mind too much that a man can have many girlfriends, or he has a wife at home and he can still have some girlfriends on the side. It's more accepted in our society. It is accepted so much so that many times when we do lectures on HIV, we risk being married as a risk factor. Because a man can go out and have his extramarital affairs and still come home and expect to sleep with his wife without the use of condoms. Again, a call for educating the women and girls. And lastly, increased, get that, increase with the ED, population mobility. Because of the war, many of our ability to produce a lot of commodities have been diminished. So people travel back and forth to neighboring countries to bring in goods for sale in the country. You look at the scenario with long-distance truck drivers, for example. They're gone for long periods without their significant other or partner. They may get involved in a sexual relationship with or without condoms, and that is a risk. So they are definitely drivers of the epidemic. Vulnerable population, adolescents and young women. Because of the inequality of power, many young women do not have the capacity or the ability to negotiate safe sex. Very often it is the man that decides when and where the sexual encounter should take place. We move on, we've mentioned the young girls engage in transactional sex and sex work. You need to keep in mind that if I need my school fees paid, my tuition paid, and you are a very handsome, young, older man who is willing to pay for my school fees, chances are I might get involved in a sexual relationship with you. But don't be fooled. You are not the only one. There are many young girls that this older, more affluent man, the phrase sugar daddy has been coined, will get involved with. I'll show you, I think I will show you, I've played with these slides so many times, the number of condoms that have been distributed. But generally for our population, condom usage is low. And if you are engaged in sex work, you get paid more money for not using a condom than if you insist. So there are a lot of underlying, I'm just giving you an overview of some of the challenges, and I'll move along quickly. Young men, of course, and clients of sex workers have increased vulnerability. Men who have sex with men. I like to say that Liberia is a very religious country, 85% Christian, and many people have difficulties even talking about men who have sex with men. We've got some rather draconian anti-sodomy laws, and people want to make it worse. The position that we have taken at the National AIDS Commission, these people are at risk. And because of some of the punitive laws that exist throughout Africa, nobody's going to come out and say, I am a homosexual or I am gay. What we do is we drive this at-risk population underground. We also inadvertently encourage that these individuals get married, have children, and live a dual life. There have been studies done, and I only know of one, and my biggest mistake is I did not get the source, but one study that was done suggested that the prevalence rate of men who have sex with men in Liberia, even though the sample size was very low, was as high as 17%. If we do not address and embrace and make treatment care and support accessible to this population, then we may never get to zero in Liberia. Often in vulnerable children living on their own will also go that step and become involved in transactional sex. They are more at risk for gender-based violence, and the list goes on. And prisoners everywhere, I will not spend too much time talking about that, and mobile population. Prevention is key. Prevention. The good news is HIV can be prevented. And so that we put a lot of money and a lot of energy in trying to prevent the infection from occurring. Three big areas that is worth looking at is prevention of mother-to-child transmission of HIV, getting individuals to come in for confidential testing and counseling, and getting people to change their behavior. Now, let's move very quickly through the national response. We all know that HIV is in our country. We know that it's in the cities and it's in the villages. What can we do to prevent and control the spread of HIV? One of the first things that we have done, well, maybe not one of the first, I don't want to put it that way. One thing we have done, because we have been working all along, was to write and develop the National HIV Strategic Framework. In the past, when people came to Liberia and they wanted to get involved in HIV work or implement programs, there was very little coordination, very little communication. People more or less did their own thing. We developed this strategic framework 2 that goes from 2010 to 2014, and it has within it the 3-1 principle from UNAIDS. One plan, and that is the framework. So now if you come to Liberia and you want to get involved in HIV work, you will take this strategic framework as your roadmap, and you will align your implementation strategies to the framework. One coordinating body, and that's the National AIDS Commission. Its mandate is to coordinate all sectors in the HIV response. I mentioned earlier that in 1986, when the first case was reported, NACP, the National AIDS and STI program, was formulated. That's a health response. They did an excellent job trying to implement a national response, but what happened, many individuals said, HIV, that's a health response. And the other sectors did nothing to include and mainstream HIV in the various sectors. The goal of the strategic plan is very simple. We want to keep our prevalence rate to 1.5% or reduce it, and we want to mitigate the impact of the virus on individuals infected and affected by HIV. The National AIDS Commission of Liberia, that's where I work, was established in 2010 with the mandate to coordinate all the HIV response in the country. I forgot to mention that the third one is there should be one monitoring and evaluation plan, so that all the players, all the actors will report to a central body so we can get a better picture of the HIV situation in Liberia. The National AIDS Commission basically has the mandate of coordination. We have the mandate to decentralize the national response. We have to move out of Monrovia, go down to the counties, down to the villages, so that everybody have access to treatment, care, and support, and to enhance knowledge about HIV. There's a commissioner for strategic information, and that's the monitoring evaluation of all the responses, one for programs and policies, and then my mandate, partnership. I have to say that with a smile because bias or not, partnership is key. It's the thread. It is common to all the various mandates. And I put this partnership thing down here, this little drawing. You've got the National AIDS Commission, we're the coordinators, but we interact with the public sector, the CBOs, the community-based organization, developmental partners, private, and the faith-based organization. Maybe somebody will ask a little bit later about what the Catholics are doing in Liberia, but that's not part of this presentation, but they are doing a lot. The National HIV Strategic Framework is funded by our various partners. We've got the Global Fund, which is the major funder of the response. Certainly we've got the UN system. We've got bilateral agencies, and we have many private organizations. The response is approximately 50% funded. The total cost was $99 million. And so there is a funding gap. We have engaged a fundraising individual to look at how we can raise funds to implement the national response. Other things that we have done, and I don't want to spend all my time talking because I'm anxious to hear some of your questions and see if I can answer them. There have been a number of different laws, policies, guidelines. One of the most important of which is the HIV law, which was passed in 2010. It addresses the whole area of stigma and discrimination. It addresses confidentiality. We do have a problem getting people to come for testing because they are afraid that people will talk, will gossip, and share the HIV status. Poverty reduction strategy has been in place and now it's grown to be referred to as the agenda for transformation. But until we can reduce the poverty level, getting to zero will be a challenge. When you look at the National Strategic Framework, almost every other page tells you we need more information on this, we need more information on that, we need studies. Between 2011 and 2013, a number of studies have been or are currently being conducted. One is the mode of transmission. You can't make a planned good interventions if you don't know how the virus is being spread within your environment. Another is the study on stigma and discrimination. Stigma and discrimination is the greatest threat to effective HIV prevention program. We know a lot about stigma and discrimination, but what face does it present in Liberia? That study is completed and we are awaiting the results. A number of studies are going on and that will inform decision making and policy formulation. What are some of the things that we have accomplished in trying to get to zero by 2015? Number one, we've ensured an effective coordination and management of a decentralized, multi-sectorial national HIV response. We have moved the response out of the Ministry of Health and put it into the National AIDS Commission. We work with all ministries so that the HIV focal person can mainstream and integrate HIV into the policies, programming of the ministries and government agencies. Once we have a good handle on the public sector, then we'll move to try to coordinate the private sector. To reduce the number of new infections among the most at-risk population and vulnerable groups in the general population with special focus on women and girls. What has been accomplished in this area is we did a size estimate. Up until 2012, we had no idea how many people lived in our society who were part of this most at-risk group. Men who have sex with men, intravenous drug users, commercial sex workers. We did a size estimate study. Everybody recognized that that estimate study grossly underestimated the number of individuals in the various classes, but it was a beginning. For the women and girls, there's an operational plan that will detail how we can best work with women and girls to reduce their vulnerability to HIV. Again, if time had permitted, we could talk at great length about why women and girls are so vulnerable to HIV infection. I merely touched on a few factors. Next, to strengthen the coverage and scale up the coverage and utilization of treatment, care, and support for people living with HIV, for orphan and vulnerable children, OVCs, and other affected. For each of these accomplishments, there are many programs that are currently in place and being implemented to try to get us to zero by 2015. When you look at the Millennium Development Goals, almost all 8 of them has an impact on HIV. To strengthen the availability of strategic information on the epidemic. And lastly, to promote a supportive environment for PL-HIV, for people living with HIV, and reduce HIV-related stigma and discrimination. Just a couple of graphs, what we have done. When you look at counseling and testing, it is a challenge to get people to be tested. The highest number of individuals tested are pregnant women because we have intensified and upgraded the PMTCT program. In 2006, the prevalence rate among pregnant women was 5.7. It come down to 2.6%, which is excellent. We're now actively encouraging every woman to make at least 4 antenatal visits to the clinic and to be tested for HIV. In the United States, the prevalence of transmission from pregnant women to their child is about 2%. In Liberia, it's 13+%. If we're going to have 0 new infections, this is one area where we have to make an impact. Testing and counseling, this graph comes from the NACP report from June 2013, and it looks at the number of people who were tested and know the results by age and category. Again, you can see far more female being tested, particularly in the area of antenatal clinics. I love this map because it shows you the facilities offering PMTCT services, and this map comes from 2013. I'm trying to think, in 2007, I believe there were only about 40 sites that offered PMTCT services. Now in 2013, we're up to 340 plus sites. This is a tremendous scale up of the services that is available. Challenges and way forward. I hope you can see that truck. This is a truck driving on a log bridge that is slippery with mud, and it has gotten royally stuck. The roadways, particularly during the rainy season, Liberia has 2 seasons, dry and rainy, and when it rains, it rains. So getting to some of the communities, getting to some of the villages can be a challenge, even during the dry season. During the rainy season, passage is impossible. This mandates that we establish strong relationship with individuals living in some of the outer counties, build up their capacity to educate and to implement the HIV response. Our decentralization commissioner has established in only 4 counties, but we're working on it, HIV people who can move this agenda forward. Mainstreaming and integrating HIV programs and policies in the public and private sectors. I mentioned earlier that each government ministry and government agency have a person designated to mainstream and integrate HIV services. We are having a workshop when I get back on what are some of the strategies and what are some of the tactics that can be used to mainstream HIV. I could also say that for many people, they still don't believe HIV is real. There's a great deal of denial that we have to work with. Many people will say, show me someone who's got AIDS and then I can believe you. And then I say to you, you can't tell by looking at a person. But that is also a challenge to get particularly young people to recognize that HIV is real, and secondly, it is preventable. Mobilizing and strengthening partnership, that keeps me busy. I want to say 24/7, but that's a slight exaggeration. Decentralizing the response is a challenge, but it's moving forward. Once we get the results from the Stigma and Discrimination Index study, we'll have a good picture of stigma and discrimination in Liberia. We want to make sure that we get to all the nurses, and because preliminary, I don't want to say preliminary, there's enough evidence to say that nurses are some of the most prejudiced individuals when it comes to interacting with HIV patients. And so we're really making an effort to educate the healthcare providers about HIV and to decrease the level of stigma and discrimination. Gender disparity, we've got a Ministry of Gender that deals with gender issues. We are working very hard and lobbying for the establishment of a gender desk within the Commission to make sure that gender, like HIV, is mainstreamed into all agencies, public and private. Lastly, empowering women. Each one of these challenges can be discussed probably for an hour plus. This is a good point for me to stop. I want to thank you very much for your attention, and I'll be happy to answer any questions. And by the way, if I don't have the answer, I'll get it before I leave here. Thank you.